Our next presentation is coming from Kansas City, obviously. It is from Ryan Schiller. Ryan is currently completing a fellowship in anatomy through Kansas City University. He is between his second and third year of medical school and will be continuing his clinical education in Wichita this summer. Ryan previously earned his bachelor's degree in physiology and kinesiology from the University of Florida and a master's degree in medical science from the University of South Florida. He hopes to pursue a surgical specialty in the future. So take it away, Ryan.
All right, thank you so much. Thank you to everyone for being here, either live in person or over Zoom. And thank you for allowing me to share my research so far. So before I get started, I just wanted to thank everyone that was involved with me in this project. And it's entitled Comparative Differences in Anterolateral Knee Ligaments, a Cadaveric Study. So there will be cadaveric images during this presentation. So a little background, this project deals with, among other things, the anterolateral ligament, which was initially described in 1879 by Paul Segond, but was discovered and named as we know it today in 2013. And in the past decade of research, it's been discovered to be a secondary knee internal rotation stabilizer of the tibia on the femur, and often undetected injury of the ALL with ACL rupture or other knee injuries can cause increased knee instability after reconstruction. So current research regarding the ALL includes sex-based differences in its anatomy by itself and also correlation data with the lateral collateral ligament and the anterior cruciate ligament. Some gaps in the research, not all of those correlational studies included differences in sex or height. And there has also been little research on potential differences in laterality, though it has been theorized that leg dominance may play a role in this area of knee anatomy. Another gap in the research is potential differences in the relational anatomy of these three anterolateral ligaments together. So the objective of this study is to investigate comparative relational differences among the ACL, LCL, and ALL with respect to sex and laterality. Secondary objectives included investigating the tubercle of Gertie as a consistent landmark for the ALL, and also just to add anatomical reference data for the ALL itself, since it's really only been going in full steam for the past decade or so. So before we get started, these are just some reference images for the anatomy of the ALL if you're not familiar with it already. Here we have the tendon of the biceps femoris inserting near the head of the fibula. We have the IT band coming in, inserting near that tubercle of Gertie, and these black dots are about where the ALL should be. If we take a deeper look, these Kaplan fibers are on the deep side of the IT band. These can be frequently confused with the ALL, but they are attached to the IT band and not to the distal femur like the ALL is. And then lastly, this is an image of the ALL in relation to the LCL. Its origin is slightly proximal and posterior to the LCL, and it inserts kind of in between the head of the fibula and the tubercle of Gertie. And this is just another reference image. We see the bands of the IT band, those Kaplan fibers, and as well as the capsulo-osseous layer right here, which overlies the ALL and is another thing that is frequently confused for it during dissection. And in the past decade of research, going through the research dive, the success rate of finding the ALL has ranged anywhere from 30% to 100%, depending on the dissection method used or its confusion with some of these other structures. So the sample that we investigated included 20 male and 21 female formalin-embalmed cadavers from the KCU Kansas City campus, as well as the UNMC Anatomy Lab. Dissection for the ALL and LCL followed that described by DeLima and Daggett. It involves bisecting the IT band proximal to the knee joint and reflecting it forward through its insertion on Gertie's tubercle. And then we investigate anterior to the tendon of the biceps femoris for the distal part of the LCL, and then run proximally up its surface for fibers of the ALL, which can be better seen with varus force and internal rotation. And then to find the ACL, the patellar tendon was bisected, patella was reflected up, and the patellar fat pad was resected. The measurements included the length, width, and thickness of the ALL and LCL at full extension. Length was taken from origin and insertion, and the width and thickness were measured at the level of the joint line. And the length and width of the ACL were measured in 120 degrees of flexion, and as well as the distance between ALL insertion and the tubercle of Gertie for its consistency as a landmark. This is an image of the structures pinned before measurement. We can see this T-pin marking the height of the tubercle of Gertie. The yellow pins are the origin and insertion of the LCL, and the pink pins are the origin and insertion of the ALL. And this that we can see here reflected is that capsulo-osseous layer that lies right over top of the ALL. But if you follow it more proximally, it originates from a different spot as the ALL. So these are some of our preliminary results. We just finished data collection just last week, so not all the statistical analysis has been completed yet, but this is some of our initial findings. This is the overall kind of demographic of our sample. The age is about the same, but overall males were taller and heavier than the females. Overall, the average length of the LCLs was about 58 millimeters. Oh, and all measurements were taken by a single investigator using a digital caliper to the nearest 10th millimeter. The average width of the LCL was about 3.6, thickness was 1.7, and for the ALL, average length was about 45.5 to 46. The width was 3.4, and thickness was about 1 millimeter. And for the ACL, length was about 35 to 36 millimeters, thickness about 7.5, and the distance from the ALL insertion to the tubercle of Gertie was consistently about 24 millimeters on average between males and females. Looking at differences between the sexes, males on average had longer, wider, and thicker ligaments than the females. This could be correlated to height as well. Now, dealing with the more relational measurements, this is kind of the values of the ligaments compared to one another. So we compared the length of the LCL to that of the ALL, as well as all the other combinations that are possible. Most of these were about the same, except for the ones that have been depicted here. So looking at the differences between their relative fractions above each other, it was found that men have more wider and thicker LCLs when compared to the other ligaments in the anterolateral knee. So going on to the discussion, like I mentioned, the male ligaments were on average longer, wider, and thicker, but this could be explained by height. And while the distance from the ALL insertion to the tubercle of Gertie was consistently 24 millimeters, it was much more variable in females, and it ranged anywhere from 13 to 30 millimeters, so it might not be as reliable of a landmark as originally thought. The lengths, all the measurements of the ligaments for males and females was fairly consistent between the right and left side. And when it comes to the relational ligament differences, like I mentioned, it was consistent for everything except the LCL. In relation to the ALL and the ACL, the male LCLs were wider and thicker than in the females. So basically that means when you look at these three ligaments in totality in the knee, males had a higher volume of the LCL compared to the rest of the ligaments than we saw in females. And as some of you may know, it's been well documented that females are more susceptible to ACL tears. And it's also been suggested that the unhappy triad of ACL rupture, meniscus tear, and MCL tear also frequently involves anterolateral structures such as the ALL. So it's this added LCL volume compared to the ALL and ACL in males could potentially provide them more protection from various forces, which may play a role in the injury mechanism between sexes and their different level of susceptibility. The most common cited difference between males and females when it comes to that increased susceptibility for ACL rupture for females is, of course, the increased Q angle from having a wider pelvis. And like I mentioned, not all the statistical analysis has been ran yet, so significance levels are pending. But based on these initial results, potential sex-based differences in the relational anatomy of these three anterolateral knee ligaments may affect the way males and females experience those stress forces in the knee and lead to difference in injury susceptibility. And also females may need additional consideration for that concomitant ALL injury and reconstruction when doing other knee reconstructions for other injuries. So some limitations to this study was the sample. It was a fairly older sample on average and predominantly white. And it was also formalin embalmed as opposed to fresh frozen tissue, which could be another study. And also the measurement technique of directly measuring the ligaments with digital caliper as opposed to any other method. As well as the ACL was only measured with length and width to not destroy the tissue. So thickness for the ACL couldn't be measured. Future studies in this topic could include a more large and diverse sample, of course, using fresh tissue like I mentioned, and also doing biomechanical studies on the stress and strain of these three ligaments together under certain forces at different angles between males and females. And these are my references, and that's it. Thank you. Any questions?
Thank you, Ryan. Questions from Kansas City? Got one back there.
Thank you very much. That's very interesting. I had a question considering the differences in the width and the structure of the ligaments in females versus males. Is there a particular graph in knee repair that's suggested for women, whether that's cadaver, patellar, hamstring, if there is a rupture?
Sure. That's not something I've come across in the research yet. I haven't so much looked at the potential differences of the graphs used in ACL reconstruction, but I do know that there is differences in the internal rotation stability afterwards. I think the patellar tendon graft has been shown to lead to more instability, and specifically with internal rotation at various degrees of knee flexion as opposed to a muscle graft or a hamstring graft. So
Thank you.
There could be some differences there. Thank you.
Ryan, I have a question related to your comment about height.
Sure.
Given the age of these individuals, they probably lost a couple of inches. You know, I can think of a couple people I know who've lost 2 or 3 inches when they're in their 80s. So close to your population age.
Absolutely.
I'm wondering do you think these measurements change, let's say when these individuals were 20 or 25 versus now?
Yeah, and
78?
absolutely. And that's why I think a further study in a more diverse population would be beneficial. And perhaps it could be something that's not dissection based. It could be more imaging based, maybe use ultrasound or CT to measure the ligaments that in healthy living participants. And it'd also be interesting to see the difference, like you mentioned, between younger individuals, maybe athletes who frequently use their knees, or compare that to an older population who may have either lost height, lost muscle mass, or anything like that.